I'm going to start by giving an introductory talk on severe asthma. As I say, I hope this is going to be very interactive because we're scheduled for an hour and a half for this session, and if it's just me speaking for an hour and a half, you'll be very, very tired indeed and bored indeed by the end. So, first of all, I have no conflicts of interest to disclose or resolve, but I am open to offers from anybody who's interested. I am going to be discussing unapproved or off-label use of a number of medications, and indeed, because I'm talking about really severe asthma, there really is no evidence base for anything. And I'm going to talk about high-dose inhaled steroids, intramuscular and oral steroids, Itraconazole, macrolides, cytotoxics such as methotrexate and azathioprine, subcutaneous terbutaline, and intravenous immunoglobulin infusions. But before all your hearts sink, I'm also going to show that most children with severe asthma don't really need this. And although the presenters haven't asked me to include this warning, this presentation will contain one slide of an explicitly sexual nature in order to keep you in the auditorium. So the aims of this session, the participants, I hope you'll understand what we call problematic severe asthma. What is the spectrum of disease encompassed by this term? And appreciate the need for multidisciplinary assessment. I think the thing that I have most learned from our multidisciplinary program is how limited are the assessments if you just rely on physicians and pediatricians. And I'd like you to, I hope at the end, be able to review the treatment options for severe therapy-resistant asthma. So, severe asthma. Before we talk about severe asthma, we certainly need to talk about straightforward asthma for reasons you will very shortly see. In terms of the basics, I am sure everybody is fully familiar with this. We know that most children with asthma are easily treated. We know that most respond to modest doses of inhaled corticosteroids and derive no benefit at all from high doses. And in fact, high-dose inhaled steroids may actually be harmful, a lesson we have learned to our cost in the United Kingdom. So the question for this, when seeing a child you think has severe asthma, is what makes this child's asthma severe, different, and difficult to treat? And this is a study which illustrates the reasons very nicely. This was from the American Care Network. They did a study in which they looked at children who were symptomatic despite high-dose inhaled steroids, 400 micrograms twice daily, and long-acting beta agonists. The aim of the study was to determine, was it better to add on montelukast or to add on azithromycin? They assessed nearly 300 patients for randomization, but only 55 were randomized. Why was this? Well, the majority who were excluded either were not taking their medicine or did not have severe asthma at all, or even asthma at all. And the lesson of this, and I'm going to show you data from our institution confirming it, is that most children who are referred with really severe asthma actually just need to get the basics right. Most of those screened were not taking their medication or did not have asthma, a really important clinical lesson for us all to learn. So what do I mean by problematic severe asthma? This is the label that a group of us have put together when you first get a referral letter from a pediatrician saying, this child has nightmare asthma, I don't know what to do, I don't know what's going on, please help. It may not be asthma at all. The asthma may be there, but complicated by comorbidities. But the stage 1 assessment, which is absolutely crucial, using our skilled respiratory nurses, divides the remainder of these patients either into those with difficult asthma, in which there are remediable factors, usually therapy adherence, and those with genuine, severe, therapy-resistant asthma. So, it's an umbrella term. Wrong diagnosis is one of the important things, not asthma at all. And I'm sure everybody looking at this chest x-ray, seeing this tooth in the right main bronchus, will of course agree that this child's so-called asthma is not going to get better with inhaled steroids. The next category is asthma comorbidities. The first one, obesity, becoming an increasing worldwide problem as people feed their children more and more fast food. Rhinosinusitis. The interactions between upper and lower airway are complex, but they undoubtedly exist. Gastroesophageal reflux, esophagitis, more controversial. Food allergy, which may be a marker of severe asthma rather than causative. And vocal cord dysfunction, a very important differential diagnosis. Dysfunctional breathing is common in asthmatics. I often see it in sports people, boys and girls who are very keen sportsmen, swimmers, basketball players, football players, who develop noisy breathing during sport or after sport. And if you can get the family to record it on a mobile phone, you will find they are making stridulous noises. Another clue here in the flow volume loop, here is expiration, and note this marked attenuation of flow in inspiration. And another characteristic of the patient with dysfunctional breathing is that the noises all disappear when the child is asleep. So we're now going to have a quiz question, and we'll take a vote, please. So, you have a child with asthma, and the treatment isn't working. Do you want the professor of pediatrics, or do you want the respiratory nurses? Hands up for the professor. Do I see any hands at all? I usually don't. No hands for the professor. One hand. I'll see you afterwards, sir. I'll buy you a beer. There are very few who vote for the professor. So is everybody voting for the respiratory nurses? Or lots of hands for the nurses. And of course, you're absolutely right. And one of the things that I have learnt from these assessments is that professors sitting in the clinic have little or no idea what is happening at home. So what the nurses do is try to separate out difficult asthma, which becomes easier when the basics are got right. And these are not candidates for novel therapies. Nobody in their right mind would give expensive monoclonal antibodies to a child who is not even taking low-dose inhaled steroids. But severe therapy-resistant asthma, it's still difficult to treat, even despite getting the basics right. And these might be the right children to have novel therapies. So what do the nurses do? This is a report of 71 children with problematic severe asthma. They did a detailed nurse-led assessment, including going home, and assessed what I call the big four: adherence, allergens, cigarette smoke, and psychosocial issues. So let's start with adherence. Remember, these are children referred to me, a tertiary centre, a university centre with really severe asthma. We get out the prescription records from the general practitioner, and you can see that 30% of these really severe asthmatics are picking up less than half of the prescriptions that they need to take their medication. Now, 45% are picking up more than 80% of their prescriptions, But of course, that does not mean they're necessarily taking the medication. The nurses go home and check the presence and accessibility of medicines. Were they in date? Were there any spares? 13 of 71, the medicines were inaccessible at the back of a cupboard, and in 8 they were out of date. And nearly a quarter of these patients could not produce a complete set of in-date medications in their home at a time when they knew the nurse was coming. 40% did not have a good inhaler technique, despite multiple attempts at teaching. 11 were using an inappropriate device, usually an inhaler without a spacer, and in nearly half of these children, medication issues contributed to poor asthma control. Now, maybe English children are more disobedient than anywhere else in the world, but I rather doubt it. This is American data. These are American data. At what age, I wonder, do you think children should be left to take their medicines unsupervised? Well, in this study, 20% of 7-year-olds and 50% of 11-year-olds were left unsupervised. And this was a problem also in our group, that a number of children were left unsupervised. And those of us who are fathers in particular, or mothers of teenage boys, will recollect, I am sure, that teenage boys remember to do absolutely nothing and walk around in a daze for the whole of their adolescence. They need to be supervised. Is the medicine going to the right place? Well, here, this doctor is no doubt giving the inhaler to the cat very effectively, but not to herself. And I worked with a nurse who also did adult clinics, and she said to me, she saw this man with asthma, and she said to him, "Show me how you use your inhaler." And he said, "I can't, because my dog is not with me." And she said, "Okay, if your dog was with you, what would you do?" And he said, "I'm allergic to the dog, so I spray my inhaler on the dog." Perfectly logical, but not correct. You never know what your patients are getting up to. Allergic sensitization, very common. 80% were sensitized to one or more aero allergens. Note, food sensitization and fungal sensitization was also common. This is the English disease. If anybody in this room doubts that the English are the stupidest race on the planet, this will prove it. 30 pet owners, 17 were sensitized to their own pet, and yet the pet stayed in the house. Data from the Cats Protection League, 1 child in 3 prefers the pet cat to their brother or sister. 1 child in 3 believes their mother prefers the pet cat to their father. And I'd be interested to hear from the married women in the audience whether they'd agree with that. But happily for me, only 1 child in 6 prefers the cat to their grandparent. 31 were house dust mite sensitized, but very few were doing any effective allergen avoidance measures. And in 22 of 71, ongoing allergen exposure was thought to be important in the home. Cigarette smoking. I was shocked by one of the posters today showing that 40% of infants who were in an RSV prophylaxis study, 40% were exposed to passive smoke. A big challenge for us as paediatricians. 23 parents admitted smoking, and 2 of the children said they smoked, and I'm sure both are underestimates. 8 homes, there was evidence of indoor smoking. And again, I'll quote my great friend Bruce Rubin. In England, of course, no parent ever smokes in front of their child. Never happens. And Bruce said to one couple, "Do you smoke at home in front of your children?" And they said, "Oh, no, doctor. When we need a cigarette, we send the children outside to play." So all smokers had detectable effects on their children, and some non-smokers too. So we measure salivary cotinine. So everybody who was exposed to smoke had cotinine in the saliva. A number of people who swore they did not smoke said that there was cotinine found in the saliva. So cigarette smoke, a big issue. Psychological factors also very important. And numbers, childhood anxiety and depression, parental anxiety and depression, very important. Now, we have long gone away from thinking that the right thing to do is to say that asthma is all in the mind. I don't think it is useful to try to say, did the psychological factors cause the asthma, or did the asthma cause the psychological factors? They're both there, and they both need to be treated. Perhaps unsurprisingly, 3/4 of the referrals came after the home visit, as parents are much more ready to open up and talk about sensitive issues in the privacy of their own home. After we've got all these data from the nurse-led visits, we then have a multidisciplinary team discussion. And in this series, less than half of the patients were felt to need further invasive investigations, which I'll come on to. The rest did not have severe therapy-resistant asthma. The rest just needed to get the basics right, and a large number of interventions were put in place. So, for example, adherence, including supervising medication, simplifying the regime, altering the home environment, psychosocial referral, attempts at smoking cessation. They didn't always succeed, obviously, but the majority just needed to get the basics right, and I'm not prepared to prescribe expensive and dangerous medications until all the basics are right. So the next step, very briefly, for those who we've weeded out, the ones who had difficult, that need to get the basics right, we try to determine, and this is not evidence-based, we try to determine the inflammatory pattern of the asthma, what I call phenotype discordance, which I'll come to. Are they steroid responsive? And do they have fixed airflow obstruction? And I'm not going to have time to show you many of the results of this. I'll just show you our protocol. So the children come up to the hospital. They have a detailed assessment of symptoms and the use of rescue medication. They have spirometry and reversibility. We do sputum induction quite safely, even in this ill population, and measure exhaled nitric oxide. And they undergo bronchoscopy under a general anesthetic, bronchoalveolar lavage, and endobronchial biopsy. While they're under the anesthetic, we give them a single dose of intramuscular triamcinolone as a steroid trial. And it is amazing how much so-called steroid-resistant asthma gets better if you know they're taking the steroids. And indeed, I will not diagnose steroid-resistant asthma until they've had this trial. So 2 to 4 weeks later, they come back for the non-invasive assessment of symptoms, use of medication, spirometry and reversibility, sputum and nitric oxide, and we try to develop an individual treatment plan, and I'll come in a moment to the options that we use. What do I mean by discordant phenotypes? These are data from Leicester, UK. Along the horizontal axis is the extent of eosinophilic inflammation, in this case determined by induced sputum. In this case, the extent of symptoms using asthma control test. And you can see within this ellipsoid here is what they call concordant disease. Low level of symptoms, low level of inflammation. Higher level of symptoms, higher level of inflammation. Very straightforward. But they see this group, an inflammation-predominant group, who have a lot of inflammation, don't have many symptoms except they get a lot of bad exacerbations. And this group, despite their baseline lack of symptoms, may benefit from increasing anti-inflammatory therapy. By contrast, this group here, with a lot of symptoms, actually have very little airway inflammation. And it seems to me to be making no sense to be having more and more anti-inflammatory medication if there is no inflammation there. So what options are there available for the rare child who has true, severe, therapy-resistant asthma? And most of this is beyond the guidelines and beyond the evidence. And this was reviewed in this article in the ERJ, published this year, by a group of us in Europe, of the evidence base, such as it is, for the various medications. Of course, the first important question to ask and keep asking is, does the child need beyond guidelines therapy at all? Are they just needing to get the basics right? Our first-line treatment, if they are eligible, because the best evidence is for this medication, is omalizumab. So if they've got severe therapy-resistant asthma, if they meet the national criteria for omalizumab, we would give them a trial. And there's a lot of evidence about this. There are a number of studies. This systematic review in Chest, big paper in the New England Journal of Medicine. There is most evidence for omalizumab in beyond guidelines therapy. However, a number of our patients, this is the IgE levels in our Brompton patients, a number of them have such high IgE levels that they are not able to qualify for this medication. The other thing we insist on is everything possible is done to reduce allergen exposure. I am not prepared to give omalizumab so somebody can cuddle their pet cat. If the cat has to go first. And likewise, if their house dust mite sensitized, they have to do sensible precautions to reduce the burden of exposure. If omalizumab fails, the next step is what we termed unusual use of usual medications. So these are standard therapies that we've all used, things like inhaled corticosteroids at high dose, prednisolone, fine particle inhaled steroids for distal inflammation, the SMART regime, a single reliever, that's Symbicort, as just one inhaler, using it both for prevention and relief, useful in adolescents. The anti-inflammatory low-dose use of theophylline, which has not been very effective in my, in my hands, and sometimes intramuscular triamcinolone. There is some evidence that in some of these children, really high-dose inhaled corticosteroids may help, but if you're going to try this, you must reduce it if there is no benefit. We start prednisolone if we can alternate day at a dose of 0.5 milligrams per kilogram and try to taper it down. There is some evidence that distal inflammation may be important. These are adult data. These are transbronchial biopsies showing inflammation in the alveolar spaces. We don't do this investigation in children. Possibly the fine particle inhaled steroids may be beneficial. We're then getting on even more to beyond guidelines therapy. The next thing we look for is severe asthma with fungal sensitization. And there's some evidence in adults. We try mold avoidance and antifungals, and I'll just spend a couple of slides on what this condition is. So this is as the adult definition. They've got to be on high-dose treatment, including either high-dose fluticasone, oral steroids, or lots of bursts of steroids, with an IgE of less than 1,000, negative IgG precipitants, but a sensitization by skin prick or test or RAST to any one of these fungal shown in the panel here. So they don't have ABPA, they are sensitized, And there is this study of Itraconazole in severe asthma with fungal sensitization. The trial design, 29 in each group, they used the AQLQ as their endpoint. Their selection was perhaps not very clever because some of these had a normal AQLQ at baseline. They were given either oral itraconazole or placebo for 32 weeks, then a 16-week follow-up. As I said, the AQLQ was the primary endpoint. The bigger the number, the better the patient. So here you can see the AQL score, the placebo in the dotted line, the itraconazole group in the solid line. There is some benefit here, not really much in terms of rhinitis, but when the medication was stopped, the benefit was lost. So in the washout period here, you can see all benefit is lost. And this was published in the Blue Journal 2 years ago. So what about children? What are our diagnostic criteria? They've got to have severe therapy-resistant asthma. They've got to have fungal sensitization as defined by the adult criteria. I never see ABPA in children with asthma. I see it in cystic fibrosis. So I don't have an IgE criteria. They don't have to have a low IgE. And I suggest that in these children, we try minimizing fungal exposure, mold in the house, stables, look at their nebulizer, are they growing fungi there, and consider trying oral itraconazole. Remember, if you're treating with budesonide, there is an interaction, and you can make the child Cushing-eyed. So if that fails, we're really at the hardcore stuff. Other agents, none any evidence at all. Macrolide antibiotics, immune modulating agents, intravenous immunoglobulins, subcutaneous terbutaline, at most a few case series and anecdotes about them. The macrolide antibiotics, there's some children who appear to have a neutrophilic pattern of asthma. Maybe this is a group that should have macrolides. There's some evidence implicating atypical infections, chlamydia and mycoplasma. Maybe it's good for them, but there's no good study in asthma as opposed to cystic fibrosis. What about the immunosuppressives? Small case series for methotrexate, less than 20 children. One case series of 5 children on cyclosporin. Maybe we should be trying some of the nebulized cyclosporin that the transplant doctors use, although it makes them cough a lot. Azathioprine, there's no published evidence for at all. No trial data for immunoglobulin infusions. Subcutaneous terbutaline, again, case series only. So those are the options. So, finally, what is KISS? What does KISS mean in this context? A better way forward. And this is for those who are still awake, this is where the sex comes. So the Brompton experience is that potentially reversible factors will be found in more than half of those who are not responding to treatment. So look again at adherence, cigarettes, allergens, and psychology. I now will not make a major therapeutic decision without getting the prescription uptake records first. One of the big take-home messages from this talk is that nurses going to the home, nurses spending time with the patients, find out far more than professors. So here's the sexually explicit bits. This is Rodin's sculpture, The Kiss, which I'm sure everybody recognizes this beautiful work of art. And KISS stands for Keep It Simple, Stupid. Get the basics right. And it's a really good rule in medicine and all sorts of things. How many mistakes do we all make because we fail to keep it simple, stupid? So thank you for listening. This is the best slide of all. This is my grandson. And I hope now we can have some useful discussions.